right. Good morning, everyone. Thank you for the introduction and bringing up my slides. I do have to say, if you hear dinging in the background, that is my SIU email. So I apologize for that. So what I wanted to do is walk folks through in 10-15 minutes. So Kareem, definitely tell me when I'm close to time. I wanted to kind of give a lens about leveraging experiences and its impact on research from the perspective of a researcher who has worked on the Tracking Rare Incidence Syndromes project since 2007. And I'll give a real quick, brief overview of how the project works, but more importantly, on the next slide, it shows why I do what I do and why working with the IWI Foundation is so critically important for me. I come to the project not with having a child with a rare condition, but being impacted by my work many years ago with three little girls, three preschool age children that had trisomy 18. And Kareem, if you could go to the next slide. Thank you. So these were these three girls we came to call our trisomy triplets. And I think what was important for context is this was in the early 1990s. I was trained, my background is in special education, so I was trained as a teacher. The two girls on either side were in my classroom, and the one in the middle was actually in the classroom across the hall. And just briefly, I had never heard of trisomy 18 before, had no idea. I knew about Down syndrome. I had heard of Cri-du-Chat and a few other genetic conditions, but never Edwards syndrome or trisomy 18. And I began working with these children and seeing that in their records, I had access to their medical records and such. There were definitely some similarities, but I saw very quickly that they had very, very different personalities, very different likes and dislikes. And it just really stayed with me because I was trying to learn more about them. Again, this was like 1992. And the internet was just starting. So I was really excited and would try to get online at 2 in the morning when you can get a little bit of bandwidth. And all I found were autopsy photos. And here I was going into my classroom and into my school every day and seeing these three girls. The two that I was working with at that time were 3 years old. And the third one was 4 years old. So that whole incompatible with life and that whole mindset, I just didn't understand from my very small sample of children I worked with. So the next slide, it's kind of fast forward to my project. And in the intervening years from when I worked with them to when I started the project officially in 2007, the internet was helpful in connecting me with parents through email groups and very early blogs and things like that, and seeing many, many more children that were surviving, but also hearing from parents about issues, again, of prenatal diagnosis and recommendations for termination, or if the child, there wasn't prenatal diagnosis, child is born, they diagnose a few days after birth, resistance to surgeries and services. So a large part of why I do what I do is in the project, I have surveys, parent completed surveys. So it's not a hospital registry or anything like that. And I ask for information. So whether the child is with us or not, I collect information. So I have the modified survey, which is for children that were lost due to miscarriage, stillbirth, or lived only up to 60 days. So it's a shorter one-time survey I ask parents to complete. And then I have what's called the baseline survey, which is very, very detailed, and you can ask Sarita about it, that collects pregnancy information, delivery, operations, medications, just a great deal of information across many areas, but also my background is a PhD. So my focus isn't only medical. In my area of special education, focusing on young children, I want the developmental information. And I think that's one of the ways I leverage what I do, is being able to talk about, collect information and talk about what the children can do. Maybe they can't walk independently, but they can use a gait trainer to get from point A to point B. Maybe they don't have speech, but they use eye gaze, or they are using some type of augmentative communication device. So once the baseline survey is completed, and it doesn't matter if a parent can complete the baseline when their child's an infant, when their child's 5 years old, there's no requirements around that to participate in the project. And then each year there's email that goes out to ask parents to do a follow-up survey to be able to provide updates. So new surgeries, new developmental accomplishments, and so on. And this is a unique component of the program, my program, of this project, is to see the change over time. And at this point, I do have some children who are not children anymore, who are young adults or older, that have been with the project for 8, 10, 12 years. And I have data for all of that time to show changes and challenges and so on. So what I wanted to do is, in the remaining slides, is kind of, again, talk a little bit more about the leveraging part and how I push information out about the project in conventional and maybe less conventional ways, that in being in this rare world for as long as I have, I do see some changes and feel that maybe I can take a little bit of credit for it. With again, pushing out information in maybe non-traditional ways. So if we can go to the next slide, this just goes kind of quickly through how the survey was developed. Importantly, there's just much of a deep dive into topics, but also constrained because I'm not a medical doctor. So I've had some very wonderful mentorship from medical doctors to help me go into all the cardiac issues and respiratory issues, and just, keep up with changes in medical technology over all these years. Also importantly, the data is collected from parents all around the world. So as long as someone can read English, and if they need to use a Google Translate or something like that, it's fine. So I do have families, predominantly the US and Canada, but also from Italy and Sweden and Norway and South Africa and all over, which is very interesting to look at some of the data trends. So again, it's parent completed, which is unique because much of the research is based off hospital data. So the next slide talks a little bit more into, again, how I'm able to push out the information. And this is just some highlights, and more than happy to go into it further with questions. Is first and foremost, again, as a researcher, I publish. I do my best with all of my other responsibilities to be able to write and to have this work published in a variety of medical journals. So what I'm highlighting here is actually a top-rated medical journal that I have been very fortunate to publish in, probably at this point at least 6 times. And what's unique too, and if you look at the poster, because I've presented at many conferences and presenting posters, just like with the articles, is I always frame it with photos of the children. And I think that is a huge difference than just reading data, even if it's very positive data and maybe changes what the current thinking is. But when I put up a poster like the one here, people will come up to me and say, "Oh, wait, this looks like a child with trisomy 18. How old is the child with the bow in her hair?" And I can say, "Oh, she's 6." And people will say, "I've never seen a 6-year-old with trisomy 18. Oh, okay, well, the child, to her right in that photo, she's 10. I think that's really, I've had, I think, pretty much positive feedback to that people just don't realize it, because of a lot of what they see and hear about these rare populations in this part of the genetic world is that they don't survive. But here I am being able to talk about and share children that are thriving. Also, the case studies and information modules, there's a link on the project's website. These are kind of a labor of love for me to get this information out and have it readily available for parents to download. And it's been wonderful to hear when parents will download an information module on trisomy 18 or one of the other conditions that I look at and take it to a medical doctor of whatever specialty, but to be able to share it. And they, as the parent, is educating the medical professional because they don't know enough about trisomy 18, but they can share the module that goes over typical issues, typical interventions, and so on. The next slide is another way that I've found to leverage the information and reaching out. And part of why I'm here today at this wonderful conference is connecting with parent-led organizations. So if you're not familiar with SOFT, which is the support organization for trisomy 1813 and related disorders, the two little logos I have here, one of the first one is for SOFT in the United Kingdom that I'm affiliated with and have presented for them. I'm on a advisory board with them. And the second logo is SOFT here in the United States. And I'm also on their medical advisory board, have attended conferences for years and presented, recruited families and such. And then we have the IWI Foundation logo as well. And then research organizations, I have, most of this has been exciting where people see my work and then reach out to me to provide updates. So here in the US, NORD, which I'm sure many of you are familiar with, has reached out to me to help update their information on trisomy 18. So I see that as a huge win in kind of leveraging what I'm doing and using that information to have at people's fingertips to look up, the diagnosis, whether as a student, a parent, a provider, a therapist, what have you. I've also worked with Global Genes for a number of years. And the next area is something that's ongoing and something that has been wonderful is just in questions through the website. I have a research coordinator that I work with. So we have information through the website, through Facebook, through email, people reaching out with questions, and they can be parents, they can be, I've had teachers reach out who say, oh, this is the first time I've, had a child with trisomy 18 in my classroom. What do I do? I've had students in high school and university level who are doing research and are looking maybe in, some type of medical biology class. They all have to pick a rare incidence condition, and trisomy 18 pops up and my name pops up with it, and they reach out to get more information. I've had social workers, I've had lawyers, I've had just a really interesting mix. I fell into a project with someone in Italy that came from her seeing my information. So that's been just wonderful. I think that's it. Right? Yes, so I also have all my contact information if folks are interested in that as well. And thank you so much for letting me share.
Hello, everybody. And I'll go ahead and just share my slide too. I've just got just one here with a little bit of information about me. Yeah, mostly I was just gonna tell you a little bit about me, and then I'm really happy to answer any questions afterwards or at the end of this session. To introduce myself, I am a rare disease advocate and a patient. I was born with a rare genetic skin disorder called epidermolysis bullosa, known as EB. And it's a condition in which the proteins that bind the layers of skin together are missing. So in my case, I am almost completely missing the protein keratin, which binds the epidermis to the layer immediately below it. So as you can imagine, that causes all sorts of issues with just fragile skin in general. Frequent blisters, I can get wounds very easily just by bumping into something very lightly. So I have to be very careful with my choice of clothing, shoes, activity. But despite my condition, which is relatively mild on the spectrum of EB, some cases are incredibly severe. I do live a relatively normal life. It just requires a lot of adjustments. And for most of my life, I was actually fairly hidden about my condition. I would, evade questions about it. I would, try to cover things up. And basically, I just wanted everyone to see me as normal and not have it be a part of my identity. For some reason, about 3 or 4 years ago, things shifted. And I decided that I wanted to use my voice to advocate for EB and for other rare diseases. And I'm not sure exactly what changed, but it's almost like a flip switch to where I was telling hardly anybody about my condition, even including close friends, to anybody who would listen. And so for the last few years, I've been a legislative advocate. I initially became involved through the Every Life Foundation of Rare Diseases. And the way that started is in 2019, here in San Francisco, where I'm based, there was a rare disease film festival. And the Every Life Foundation actually had a booth set up there. And I learned more about them. And I decided on the spot that I would attend Rare Disease Week on Capitol Hill, which took place a few months later in February 2020. And really enjoyed the experience of talking about my condition and explaining to the offices of my legislators why they should support legislation that ultimately benefits rare disease patients and all patients with rare and chronic conditions, actually. And one thing led to another, and I joined the Every Life Foundation's Community Congress just a little bit later that year. And I represent an organization called EB Research Partnership, who strives to find treatments and cures for EB through fundraising and venture philanthropy. So I represent EBRP on the Community Congress and bring to them issues that they should sign on and opportunities for them to be supported by Every Life. And so that's been very fulfilling. And over the past year, and this is part of how I know Sarita, I've been on the RDLA Advisory Committee of the Every Life Foundation and help the organization prepare its future advocates for raising their voice and empowering them to share their own rare disease journey. And so it's been very fulfilling. And another facet of my experience is clinical trial participation. For most of my life, there was actually also no treatment on the horizon whatsoever for EB. There were a few experiments going on here and there, but really nothing gaining any traction. But over the last few years, that's really changed. And a few years ago, I was in a clinical trial for a oral anti-itch medication. Itch is one of the predominant symptoms of EB. And as you can imagine, having a symptom like itch and having fragile skin, it's a terrible combination. And all of the topical therapies, standard therapies, do not work for EB itch, which is nerve related. And so I was in a clinical trial a few years ago for that medication. The trial was, I think it lasted about 3 months. And then I also had the option of taking the active medication for another 3 months. And throughout the trial journey, in addition to, of course, fulfilling the requirements in the trial, I also gave feedback on how the trial could be more patient-friendly. Since there were some aspects of the trial that were very well run, others that were, let's say more difficult. And then just last year, I was in a second clinical trial, and this was for a topical gel that aims to strengthen the skin. And one of the exciting things about this trial is that the medication was for my specific subtype of EB, for which there really hadn't been any trials to date. And so this trial was even more involved. It was shorter, it lasted about 6 weeks. I just had to visit the clinic at the beginning and the end, but it was much more extensive in terms of my involvement. It involved biopsies, it involved multiple lab tests. And, you know, again, just like with the first trial, and actually even more so, there were some aspects of the trial that went very smoothly, and others that I thought required great improvement. I felt that there could have been better communication with the patients about certain aspects of the trial. I felt that the certain aspects of the trial could have been better organized. And I felt that there could have been clear instructions in terms of, post-biopsy care, things of that nature, because, that was one of the complications I ran into towards the end of the trial. When I had the end biopsy, there was an issue with the healing, and I wish that I had gotten better information up front about this potential complication and proactive information on how I could how I would handle it if something like that were to arise. And so in that sense, through my participation, I was able to not only give the clinical trial team data about how I responded to the medication, but also was able to shape the future of the trial by making it much more palatable to the future participants in the trial. Since I was actually patient number one in that trial, there ended up being 5 other participants, and my hope is that they had a better experience than I did based on the feedback that I provided to the trial team. And, this experience has really taught me that, with clinical trials in particular, it is very important to listen to the patient, and they should actually be involved very early on in the process in actually developing the protocol, the consent form. I think there needs to be a way for patients to have that early touch point with the clinical trial team, because especially with a rare disease, they know their condition best, and they're able to provide input on, are certain aspects of this trial realistic? Are there, for example, certain areas of the body that should not be biopsied, which is something that I discovered, during the trial, and so hence the protocol was changed after I expressed my concerns. But I do think that really having the patient involved early in clinical trial development and drug development in general is really important. And so that's something that I've become really passionate about, making sure that the patient voice is heard when treatments are being developed for their benefit and for the benefit of the community. So that's a bit about me, but just hoping to have this be interactive, and really happy to answer any questions that you might have about my advocacy work or my clinical trial participation, or just living with EB in general.
Thank you so much for sharing. So just to introduce myself, my name is Donovan, Donovan Dennis. I was gonna also just share a screen real quick to talk about global genes that was mentioned briefly. Okay, but before I do that, I'll just reintroduce myself. My name is Donovan Dennis. I am currently a second year MD MPH student at Michigan State University's College of Human Medicine. So I'm studying to be a doctor and also pursue my master's in public health. I'm officially a second year as of this week. So like in the middle of exams and everything, new schedule. But very excited to be here. And let me just share something really quickly. And so how I got involved, if everyone can see this, I know it was brought up earlier, Dr. Bruns had mentioned Global Genes, and just to sort of speak about that for folks who maybe aren't familiar, Global Genes is this awesome nonprofit organization and community forum that has like a global community, and it allows people who either have rare disease or care about rare disease to really just stay connected, talk about things, talk about experiences, this diagnostic journey that we've talked about earlier in this conversation. And how I got involved, they have a specific program called the Rare Compassion Program, which is an aspect of the forum where med students who want to learn more about rare diseases and like how to advocate for patients get connected with people who have rare disease, who opt into the program. And it's very informal. It allows us to sort of have a longitudinal relationship, share experiences. And you can imagine this is awesome because there's not enough, from personal experience, there's not enough in medical education about rare disease, how to have conversations, how to diagnose. And it's so sad because like there's like thousands of rare diseases. And while a lot of them are nuanced and difficult to diagnose, doctors are not going to have that competence unless we speak about it and gain experience and really talk to patients. So we as med students have so much to learn from patients, families who have these narratives to share, like who are willing to share their story. And the program, which is how I got involved and how I met Sarita, was through this program. So I'm really excited because it's a way for me to learn and listen, as was spoken in the earlier session, listen and sort of build experiences with those around me and form a global community. And that's honestly how I've gained this passion into advocacy, genetics, and really just supporting families. So I will stop my share here. And again, just thank everyone who's shared their experience so far. I think it's really critical, like for me thinking as I become a future provider, like I'm going to be like dealing with like difficult cases and like emotional cases. And I'm at the end of the day, it's going to be my job to support my patients and support the families. And that requires listening to them. And I really liked what Nisha just mentioned about like involving the patients, like that early touch point, because when we do research and work, like we as providers, as advocates, we have to, like folks who are dealing with rare disease and rare illness have to be at the center of the work, have to be at the center of whatever the work is being done, because they should be involved. And that, like a little plug for Michigan State and our curriculum, we have something called the shared discovery curriculum. And what that means is that it's like very much intentional about involving and centering the patient, because it's the patient at the end of the day, their body, their experiences. I'm going to bring some medical expertise, but we're a team. Like I'm not going to be talking at my patients. I'm going to be talking with my patients because we're a team. So we talk a lot about involving the patients in their care, because that's how they're going to be like best informed. That's how they're going to be best adherent to treatment. Like they should be involved, and it's a team effort. So that's my little 2 cents. But I had a general question here that I was going to just start off with for our panelists. So specifically in the case of our panelists, by either having family or personal experience with rare disease, how would you encourage others in similar shoes to leverage their own experience for advocacy? So like any tips or trade that have worked for either of you?
Sure, I can start with this one. I think one way to ease yourself in, if you're relatively new to advocacy and raising your voice, is definitely through social media, and that's something I realized I didn't mention when I was speaking, but it was the very first time that I came forward with my story was a Facebook post on EB Awareness Week. And this one was the one that took place 4 years ago, and just posting about my experience, what it means to have EB, and my commitment to to continuing to raise awareness for the cause, and just got a lot of support from family and friends that way, and I felt like that gave me the momentum to keep going. I think I did share my story on the Global Genes portal that you pointed out just now. I think I did that shortly afterwards, and then through other forums like Patients Rising, and then of course, as I mentioned, I joined the Every Life Foundation and started telling my story in meetings. But I think social media can be a really good place to start and gives you some of that early momentum for sure.
I guess I come at that from a slightly different way, because with the TRICE project, what we're doing, the focus is on the children, who many cannot speak for themselves. And it's a parent, caregiver, close, professional that's worked with them over the years. And I think that's part of where my thought is with the photos, because, a picture is worth 1,000 words. So what I shared of what struck me back in the day is seeing autopsy photos and then seeing the children in front of me, smiling and being like mischievous and, showing preference for people. So when I started the TRICE project, one of the first things, once I got the survey situated, was I went into a photo release form. And I shared that with parents, and they were all very excited about sharing their child, and kind of gave me license of, if I wanted to put a photo in a PowerPoint, if I wanted, I have a brochure, I do the posters. I've been very, very fortunate to be able to include photos in all of my research articles. And I think that's been, how do you say that it's incompatible with life when you see this smiling child in a swimming pool, or, we've had some of the kids that, and it kind of goes back to the family too, because some of the parents want to kind of bubble wrap them and not go out into the world as much, which I respect. But then I also have, families with children that they just pack them up and take them, like they're part of the family. So even if they have events, they pack them up and go to Big Brother's baseball game. And I think that's just huge, because it's, oh, this is our family. Oh yeah, she's got a couple pieces of equipment. Oh, she looks a little, oh yeah, she has trisomy 18. And I think it's that grassroots way of just, so the next time you see the child, it's no big deal. Or the next time you see someone who looks like that person, it's no big deal. And I think, as I mentioned, like with SOFT and some of those types of groups, I can't tell you the amazing experiences that I have seeing so many people in one place, and having a new parent walk in who is not thinking about advocacy. They're just trying to like keep their head above water with their baby. But then they see all these people who are excited to see them and their child, who are like coming up and grabbing and cuddling their baby with a G-tube and a trach and everything else. And they've kind of found their people, and they pick up some of that advocacy and confidence to go back home and like sit the doctor down and say, you know what, we are going to do heart surgery. And I heard about this doctor out in Nebraska, so I'm going to go out there, and they'll make it happen. And that's where I see amazing, like, leap into advocacy types of things that happen. And I feel, again, like little bits that I can do with the project to help that along.
Thank you. I love what both of you shared just now. I'll start with social media. Absolutely. I think social media, like for better or for worse, is sort of like this point where, like, in general, one of the best things about social media is access. So like with like literally, this is how I met Sarita. This is how I got involved with IWI, like through Global Genes, this forum. Like I was able to connect with people from across the globe, and learn from them and converse with them. Like we can connect with people. And I think that's one of the best things, because when else am I going to have the opportunity to chat with someone from across the world with, totally different lived experience for me? I think there's a lot of power in that. And I think that's a great way to sort of get into advocacy. And as was just mentioned now, like even just using the word of advocacy can like sometimes maybe turn people off. And I think that's unfortunate, but that's just the nuance of language. Like a quote that I sort of thought of was like with language comes power. And anytime we have power, we can have harm or we can have healing, but we need to be responsible. And folks who have certain privileges, so like thinking doctors, like a doctor that I will become, like I need to be cognizant of that, because like the language that I use will affect not only my staff but the patients. And like as you just mentioned, Dr. Bruns, like one of the things that I hate when we were learning about, like even me as a med student, like learning about the different trisomies, like there's that consistent theme of, oh, inconsistent with life, incompatible with life. And I think that's like, so it's really insensitive. And then for those that do survive and are living with the diagnosis, like what sort of message does that communicate to these families? I think it's really harmful. And it's really easy to just change the semantics, change the nuance of the language, because language is power. And like by just changing that language, you can have a very different patient-provider experience.
What I've learned, and again, I'm not a medical doctor, so I've had to fight my own battles for people to like recognize my work. And I see that as in some parallel, right, to what families are going through. But I understand what you're saying about advocacy, because a lot of people are like, okay, back down, like stop. But it's also leadership. And that's something that I've also studied in a different context in like early childhood special education, which is like my home. But just that whole idea in talking with families, like, you are a leader. It's not because of letters after your name. Like, I can't tell you how many parents I've talked to, Sarita included, of like, you know a lot more than I do because you live with it every day. I'm looking at the data. I'm trying to keep up on the research and can tell you that in the past 20 years, yes, things have changed because now we will do cardiac surgery, you know, and not just do the Band-Aid surgery. We'll do the aggressive treatment of a VSD, of a PDA. But if the child has hypoplastic, you know, then we won't do it. Like, I can talk the lingo now, but I think it's that leadership of a parent who, and I've had parents in the project who are teenagers and have a baby. I've had parents who are 45 years old and have a baby and have a whole bunch of degrees. But coming into this rare world, we're all starting out in the same place. And then to support parents, and like, I've gotten pushback of, well, you're just sharing the kids who are doing well. We don't want to have parents be like over optimistic. But you know what? Why not? Like, anyone can be a future president. Anyone can be a future Olympic athlete. So yeah, if I show parents, but I say, this is this child, that's why I have the case studies. Like, okay, yes, this child successfully was decannulated, had heart surgery, but why don't you want to share that and celebrate it? Even if the child, your child, may not be a candidate to be decannulated. Like, you still know it's a possibility. So you can ask for a second opinion. And then the second doctor or the third doctor says, probably not for your child. But like, you've done, that's to me like the leadership part of it. And I've had parents many times who are like afraid to ruffle feathers because, oh, I just finally got my medical team in place. And I'm like, but if you don't like the orthopedist, find another one. You know, go to social media and talk to parents in your state or in, you know, whatever that context is. And I feel like I've sometimes helped light a fire under people to be like, you don't have to just take what they give you. You can fight. You can say, no, my kid deserves more therapy than they want to give them. Like, I saw that in my classroom. Oh, we don't see, you know, the physical therapist doesn't see any progress in 3 months. We're going to cut PT. And I'm like, heck no, that's the point. Keep working with the child. Don't ask me as the teacher to become the PT. You have a different skill set. Work with that child, try some other things, try some other equipment, instead of just saying, oh, there's no progress, so we're going to drop them. So.
Yes. Thank you for sharing that. Like, that's that support. And I think, like, even with, like, for those of us who are supporting and advocating, like, whatever that means, like, that's when systems of support are important. Because, like, some people, like with fighting, some people really don't know resources, don't know how to fight, or as you just sort of described, it's like you're just sort of dealing with like really poor medical care, and it's like, well, what do I do? And that's why we need support. Like, that's how folks can best leverage their experiences. Like, we have to build these communities of support. We have to share our narratives. We have to stay connected, because like, that's how we can get to the next step, whether that's research, clinical trials, policy. Like, if everyone's silent, what's going to happen? Like, we have to speak up. And I mean, there's labor in that. Like, it's tiring, but we take breaks, we support each other, we check in. That's why there's like, it's not just movement isn't one person. It's not like the singular thing. Like, movements require multiple people, multiple perspectives, multiple expertise. So yeah, thank you. I really appreciate what both of you.
That hits all my buttons when those conversations come up, for sure.
Yeah, it's sad too, because even as a med student, like, I see these sort of experience, like I've already experiencing these from other doctors who are like older than me, and there's very much that dynamic where like, oh, well, I've been in it for years, I know what I'm talking about, I'm not going to change my language.
Right.
It's really sad, and just, this is why we need more people. We need younger doctors, we need doctors who are more culturally sensitive, and willing to get into these conversations, because like, yes, go ahead, please.
The only thing I was going to say, and Nisha, I'll stop talking, but that's what I don't understand, because like, as a researcher, I'm always reading the new information. I mean, I get Google alerts. So anything that comes through with trisomy 18, I'm on it. And so why are these people stuck? Like, you know, anyone, whether they're a doctor, a teacher, a therapist, like you're supposed to keep up. That's part of your professional responsibility. So when I say, oh, more children are coming out of cardiac surgery, I'm not making it up. I'm not just saying it based on what I see in my data set, which is imperfect in many ways, because it just is. But I can say all these folks in Japan are like miles and miles ahead of us in the US in providing care for kids with trisomy 18, for example. And I can show you literature from the past 5 years that's come out of Japan. So I get really frustrated when the doctors here aren't keeping up and they just have the old stuff that's all the incompatible with life and the autopsy photos. Even like I forget the name of the book, but like the Bible on genetic conditions, that big fat book, I forget, that Smith, I think, was one of the authors. But so it gets updated, and I've helped update from my project. I've helped update the trisomy 18, 13, and 9 mosaic entries because it was all gloom and doom. And I'm like, why is this the book that everybody goes to versus like the clinical management book that like Dr. Carey's involved with, who is the guru and mentor for like everybody in the trisomy 18 world. And it gives more of a natural history with detail than just like a 1-page, these are all the problems and they don't live. So I'm done. That's just a soapbox thing for me. I just can't wrap my head around why I need to keep up in my world and read the journals and do all that. But then an orthopedist or whoever like isn't reading even some of the basic American Journal of Medical Genetics stuff. Well.
Yeah, this is the importance of data. And like when we have things like clinical trials, like we need more participation, we need the presence of this. And I actually have a question specifically for Nisha from the panel, or for the panel. Were you or other patients part of framework design of the clinical trial that you participated in? And then were the outcomes aligned with patient goals versus trial goals?
Oh, those are really good questions. The answer to the first question is unfortunately no. And I think that had patients been involved in the framework design of the trial, it would have gone more smoothly. And I think, yeah, actually, I think that's the main part. It would have gone more smoothly. It would have been more patient-friendly experience, which in a lot of ways it wasn't. For example, I mentioned the complication with the biopsies. There was also kind of a lack of technology in the second trial. Like I'm filling out paper diaries in the year 2022. That's that's probably not as optimized as it should be. And then in terms of, can you remind me what the second question is? I think I also have quite a few thoughts on that one, but I just want to make sure I address the full wording.
Yes, absolutely. Were the outcomes of the trial aligned with patient goals versus trial goals?
Good question. Also, I think with the first trial I was involved in, perhaps. I unfortunately in that trial did not see benefit from the medication. But the EB community is small, and I know that other people had a more positive experience. So I believe that it might have been. For the second trial, and that one is just closing, so there's not too much I can share in terms of the details, but I can say, and actually this goes back to the earlier point in terms of getting the patient involved and the patient voice, because there was, I know, some confusion about how long should the trial be, because the protocol defined improvement in a way that was very, it was a bit vague, and it was not necessarily in line with the way the disease presents itself, right? So for example, this is a medication that's supposed to strengthen the skin. And so they partially measure it in terms of presence of blisters and wounds before and after. But the thing about my subtype of EB is we don't have blisters and wounds around the clock. So if you're looking at let's say just a few week period, you're not going to get a full realistic picture of how the condition presents itself. And I remember at one point over Zoom giving the giving the whole clinical trial team a lecture on this. And as a result of that, we actually did end up extending the period of the trial against what the protocol might have said before. And, what that suggests to me is that, again, the way that the trial team, the sponsor is thinking about outcome and the way that the patient is thinking about their condition, there's definitely a disconnect. And that all goes back to having that patient involved early. And that's why it's so critical.
Yeah, that's disappointing to me because I would like to even like, it's great that they like are willing to adapt, but then it's like, it just makes me think from the beginning, who was involved when this was started? Like, is there not like, clearly there isn't some sort of like insider or, like intrinsic sort of connection to whatever there's that's
Exactly.
Mhm.
I mean, again, that to me, that's why I do what I do. Like, I didn't just wake up one day and I wanted to research trisomy 18. I've been invested from way back when, and like being in this world, I've met a lot of people, who had a child that's not living now, but that had them when it was really the whole incompatible with life, and had some really interesting conversations, of I wish we knew now, knew then what we know now, and how do we help, and I know this is way off field, but when all of that prenatal testing was starting to be pushed, that earlier, prenatal testing and stuff, the whole community, everyone was freaking out about it, because they're like, we're finally making an inroad to see the quality of life for these kids and giving them a chance. And now everything is this prenatal, more intensive testing and trying to push people to terminate. And there were a lot of factors going on, but just the community and like people talking on social media and at the conferences, it was rough. It was a really rough time at that point, with like a lot of the parents that had the younger babies saying, wait a minute, look at my baby. How can you tell me to terminate because of trisomy 18, or they turned out to be mosaic and they didn't have as many issues, but they were testing as full. And so I think all of it is just giving the parents and caregivers that voice and saying, my child may be the unicorn, like not that long ago, nobody was giving trachs to kids with trisomy 18. Now lots of kids have trachs. And I feel like, again, there was something with getting it out there and seeing that some kids could be decannulated, seeing, that quality of life is impacted when the child can breathe. I mean, why do we have to make that argument? Yeah.
Yeah, and as a comment was just put in just recently in the chat, quality of life is essential. And as we update our data, as we involve folks who are in the community that we're like studying, involving, like we can get more like updated, inclusive information that can then inform treatment. And like, this is important because we're trying to improve quality, right? Like we want more positive statistics. We want to bring people together. So that's important, because like with data, it becomes more powerful to advocate for policy, to advocate for law, and then that can reflect in treatment, and we can just improve the health. So we need that. And okay, it looks like we have another question here. I know we're getting close to time. This question is, how do you navigate trusting researchers to have your best health interests at heart? Love this question.
Sure. That's a tricky one. With the trials that I participated in, something that was unique was that, or at least for the second one, I was already familiar with the doctors on the trial team, which is not always the case, right? A patient might be traveling to a trial site, they're going to meet the whole team for the first time. In my case, I did know the doctor and trust the doctor. I didn't know the full trial team, but at least, the person who was heading up the study. And so, that part was a little bit easier. But I felt like I had to speak up, quite a bit about, not only the trial design, as I mentioned, but also, for example, in certain procedures. In the first trial, I had to have an EKG done, and a tricky thing for an EKG is that it involves sticky leads, and people with EB have really fragile skin. Adhesive is not going to work. And I had to, they asked me, oh, can we use paper tape? And I said, absolutely not. And why are you asking an EB person that question? And so I was constantly on guard from that moment on. Every single procedure that was done, I was watching them like a hawk. I remember during the second trial, for the biopsies, they had all of the materials laid out, and there were two Band-Aids there with adhesive. And I said, I want you to throw those away right now. I don't want you to accidentally use them out of habit right now. I want to watch you dispose of them. And so there's already this like lack of trust and defensiveness on my end. And so it's not as though I thought, oh, they don't have my best interest in heart, but in a trial context that is focused on my condition, I had to be hyper aware of making sure that I wasn't harmed, right? It is one thing to, let's say, go to a doctor's office for an entirely different procedure, go to my dentist, they're not experts in EB and I have to educate them, and that's absolutely understandable. But when it is a trial for my specific condition, this is the baseline level of knowledge that should be understood, and the patient should not be burdened to educate the team about something that they're supposed to be an expert in.
Thank you. Yeah, I agree. Especially in cases like that, the burden really should never be on the patient. It should be on those who are like part of the team, part of the research, the medical, the advocacy team. Like we have to do the work. And that's why, as sort of was mentioned earlier, like you alluded to, we need to have people involved from the beginning, like at the protocol level, at the base, because then we don't have to, like, these uncomfortable situations, these moments where we are like ruining trust, like don't have to happen. Like the likelihood of them happening is less, because we sort of, like, from the beginning, the planning process, we know the basic knowledge, and that's not going to happen unless there's some sort of insider source like that. That's just fundamental.
I think what I picture in my head is the like top down versus bottom up. Because, again, and I have utmost respect for medical doctors. Don't get me wrong. I do. I really, really do. Because they do magic, right? But if you haven't been around like the children, you have no idea. And you're just like coming up with this protocol or coming up with this prognosis. So like for the trisomy 18 world, Dr. Carey, who I mentioned, he's like the guru guy, but he's also the one, like when we were at the conferences together, he seeks out like the new families and sits down with them and he listens. He doesn't sit there and tell them what's going to happen to their child. He says, what are your questions? Send me the records and I'll take a look at them. And I think that's part of why we've seen at least a little bit of change, like in our little world, because we have someone like that who began with some of these first parents that were going through this many years ago. Like how he helped found this parent-led organization because of an interaction with one family. That he's out in Utah, and that's where it all started. So I think that's the difference, and I feel like that's why I can slide into this, because I'm coming from a developmental perspective. I'm coming from working in a classroom where you work closely, with parents and social workers and like all of those people, versus, the child with trisomy 18 comes into my exam room. I'm going to check some things. I'm going to look at something, and I'm not getting like that full picture. Like for me as a special educator, I need the full picture, not just of what the child's struggling with, but what can they do? What do they enjoy doing? In our world, like our birth to 3 world for early intervention, the family is a core part of everything, including the planning documents. So when you're making decisions on what to work on, and you want to work on your child's feeding, and you want to work on your child's motor skills, if a parent wants to go back to school for nursing, it gets written into the program. It gets written into that plan. And everyone's involved. So I've always had this like bottom up, top down thing. And I think sometimes being around the medical folks, it just makes me upset, because so much of it is that top down old way of thinking, I know best, where you have to listen to the parents. Maybe they don't have the jargon, maybe they're not polished, but I've seen a mom who advocates, her child has 8 mosaic and he's in his 20s and she barely finished high school. I mean, not the most articulate or anything, but she has opened a path for him as an adult, to be listened to and move over to the adult side of the medical world, which is really scary for many of these families who never thought it would even happen, that they had to think about it. And she makes noise. I mean, with a doctor, with a team, at a clinic, and she doesn't think twice about doing that because it's for her child who can't speak for himself.
Mm-hmm. And one really quick thing I'll add, going back to the trust of the trial team, is also just the protocol design. I know at one point in the second trial, the sponsor was trying to get me to take photos more often than was agreed to. And to me, it felt like it was data for the sake of collecting data and not thinking about the burden on the patient. So I think a way that the researchers can increase trust among the patients is to make sure that they're fully aware of what they're expecting them to do and whether that's necessary or not.
Thank you both for sharing those responses. With commenting on what you just shared just now, Nisha, what I think, as I'm trying to conduct more research as a provider, as an advocate, and as I'm having conversations with my mentors, we're learning that consent, establishing consent is not this one-time thing, but in good research, it's fluid and it's continuous. And that requires multiple stops during the research, making sure the patient is aware, the participant, whomever, is making sure there's active communication. And in a moment like that, that could create some huge harm. I don't want to be some sort of, I'm not an object, I'm not a subject, I'm a person in the research. So I really appreciate that point you just mentioned, because nobody wants to be we're not a museum. Nobody wants to be seen just a museum exhibit.
Mm-hmm.
We're a research team, right? You can't do this research without me. We should be working together, where no one feels alienated. I think that's important. And a lot of times, getting to a point that Dr. Bruns mentioned, I really appreciate what you were alluding to with really just the work of parents. And I think what's one of the things that I've learned by just with my involvement in Global Genes and the Rare Compassion Program, which I just started this year, is that what's unfortunate is that so many people who have rare diseases have to become they have to become advocates. They have to learn the medical jargon and the language for their own care. And I mean, there's power with that. They gain the language, they know how to navigate the health system, but that takes trial and error. That takes a lot of effort. Some people, I don't want to have to work. I don't want to be an advocate. I just want to be a person. But what you mentioned about leadership, I think is important, because you don't necessarily have to have medical expertise or degrees to advocate or be a leader. And with what you mentioned about the mother, paving the way for her child, is powerful, because by even doing that, I would argue that that's, advocacy. You're supporting someone, you're raising awareness, and that's beautiful. That's power. And that's how we can change the narrative, as mentioned earlier, and leverage experience for positive change. So I think these are all really important points. And these are necessary for this diagnostic journey that we talk about. And let's see, I know we have a few more minutes. There was one question that I just wanted to sort of pose to our panelists. Okay, so how much is too much or too little information to share with those who are unaware or have limited knowledge in relation to the rare community experience? How much is too much or too little information?
I think I know that when I practice legislative advocacy, one of the things that I'm always mindful of is not sharing too much scientific or medical jargon, right? They don't need to know where the gene mutation is or even what the protein is. What they need to know is, how does EB impact my life? Or, simple analogies that help them realize what it's like to live with fragile skin, and really keeping it, simple and conversational, and relatable, I think are the keys. I think once you get into a lot of the details and the scientific stuff, for a general audience, that's when it can get difficult. So I think really keeping things as relatable as possible allows one to be most effective.
And I definitely agree. It's all about the audience. So that's why for the project at the beginning, for me, it was really like publish, right? Because I can reach people that way. But then it started moving more to the parent questions and taking like direction directly from parents of what I should be looking at, because I have so much data. And, their child has an issue with reflux. Oh, I can go down that rabbit hole. I have data, about reflux. But then it's like, how do you package it? And I think the academic journals is important, but when I started doing like the case studies, I feel like many more people can use those. And then I went back and updated some of the kids that were in the case studies who were still living and thriving, and kind of give an update 3-4 years later of how they're doing. I've developed information modules that have kind of the mix of things that could help a parent or a teacher who's going to work with a child, but then there's also reference lists and there's a glossary. And so I think that's the leveraging is like, I can take all this information I have and I can present it to different audiences, where I could like take a lot of something I put in an article about reflux or cardiac surgery or something. But then when I package it into a case study that details a child who's had 2 surgeries and what happened afterward, or the information module will have some slides in there specific to surgery. And if you don't want to look at them, you just go back, you go past them. So it's weighing your audience, and sometimes you just have to do too much, I feel like, because I go in saying, I assume you don't know very much at all. So I'm going to talk to you about the person who named Edwards syndrome first, to give you context of when that happened and when, other people started looking into it, and some of the first studies about it and the case studies about it, and then update to what's going on now. And if you don't want to look at all of that, it's fine. You can pick and choose, but it's all there.
Yeah, I appreciate what you both are getting at here. Like, it's about like adapting the message and knowing your audience. Like any sort of mode of effective communication will require that you know the audience, you know how to sort of package and communicate the information, and sort of do this balance between, okay, too much, too little. I don't want to give too much where it's like jargony, I'm turning off the audience, but you don't want to oversimplify, because like making it relatable really is like, as you said, like it's just really powerful. That's how you can make it memorable. Like you make it relatable to the audience. So you have to know audience, meet them where they are. So sometimes that involves some teaching, but like making it memorable and relatable to them is how it can be most impactful, I would say, and summarize. So thank you both so much. Any final thoughts? Anything you'd like to share as we conclude this session?
Yeah, one thing I'll say is that, we've talked about how advocacy can be difficult, and, we, just want to live our lives, which I definitely, absolutely understand. But I think one of the things I found rewarding about the journey is, finding that support network and realizing I'm not alone, and having had adverse medical experiences or feeling isolated, or having to just deal with the day-to-day challenges of living in the U.S. healthcare system. So that has at least been the positive, for me, is to build a community of people, and really meet just some amazing individuals who are on this path. So definitely embrace that part of it.
I would agree with what you just said, just from my slightly different perspective of just, it's been, my own journey with just meeting parents who are at different places on the journey, who don't even realize like the power and strength that they have. And then you'll kind of see sometimes that they get it. And they're really nurturing, you know, the next group of parents that are coming. And then they're the ones who just kind of want to do their thing. And, you know, I've talked with many parents who don't. I'm like, oh, you could join this Facebook group. And they're like, nope, I'm good. I'm okay hanging out here on my own. But I'll just make sure that they know that there's other people they can reach out to, or they can come back to me. So I kind of, everyone has their story and they tell it the way they want. And I think there's always the leveraging is always there. It's just going to look different in each situation.
Thank you both again for sharing your stories, your work, your expertise. This is inspiring just for me as a student, like who's going to be a doctor and is going to be an active advocate. So just thank you both again for sharing all of this.
Of course. Thank you for having me.
Thank
Absolutely.
you. And thanks, Sarita.
Yeah, thank you,
Yes.
Sarita.
At this point, I will turn it over to them, and we will, I believe, be starting the next session.